good afternoon. It's my pleasure to start our session, Challenges in the Management of Breast Cancer. First of all, I'd like to thank Professor Amani Hilal for her kind invitation to share in this great meeting. And it's my honor to present our first speaker, my dear Professor Wafa Al-Mitnawi. She will talk about the genomics changed the landscape of breast cancer management and prevention.
بسم الله الرحمن الرحيم. أولاً بشكر الدعوة الكريمة للاشتراك في مؤتمر بهية، والحقيقة يعني الدكتورة أماني هلال، الدكتور أحمد مجدي، الدكتورة هبة الظواهري، هي فرصة عظيمة إن أنا يعني أقابل كل الناس حبايبي يعني وقرايبي وجيراني، منهم الدكتورة هبة الظواهري. الحقيقة يعني هو جالي 2 personal programs. واحد قال لي هتقولي الجينومكس change the landscape of breast cancer management، وجالي personal program تاني قال لي هتقولي polygenic risk score. فأنا الحقيقة قلت طب والله لا أقولهم الاثنين، يعني اختصرتهم بحيث إن أنا أدخلهم الاثنين في بعض. هبتدي بالصورة دي. الصورة دي بتقول كل واحد فينا موجود هنا مكتوب على الهيومن جينوم بتاعه his risk for any specific disease، diabetes mellitus، cardiovascular disease، أو كانسر أو بريست كانسر. فمكتوب على الجينوم بتاعنا certain informations، يعني architecture معين بيقول إن في susceptibility to certain disease. طبعاً إحنا هنا بنتكلم عن البريست كانسر. لما نيجي نشوف الهول population of breast cancer هنلاقي زي ما أنتوا عارفين جميعاً الكاتيجوري الفيري aggressive اللي هي triple negative breast cancer اللي هم carrier of gene mutations in the BRCA genes، دول يمثلوا 5 ل 7 ماكسيموم 10%. إنما الفاميليال بيمثلوا familiar for genes written but not detected, not identified on our human genome. دول بيمثلوا الفاميليال 20%. طب الباقي what is the risk of the other population؟ الحقيقة المعلومات دي كلها قدرنا نتعرف عليها من السيكونسينج اوف ذا هيومن جينوم. الهيومن جينوم بيقول ان في اديشن او في اديشن طلعت سنه 2003 published in Nature، وفي اديشن جديده published 2 years ago في 2022. ما علينا، في كل المؤتمرات of Arab health women في specific challenge of growing morbidity and mortality associated with breast cancer in the Middle East. وده طبعاً is very important for healthcare experts. وكذلك الميديان diagnosis عندنا هنا في مصر وفي الميدل إيست is 10 years younger. ده معناه إن في must be more comprehensive strategies for risk stratification. الريسك stratification ده لحد دلوقتي ما احناش قادرين نوصل له completely. قدرنا نوصل لبعض الكاتيجورايزيشن and risk stratification من الهيومن جينوم اديشن 2003. طبعا احنا عارفين ان الكوست of diagnosis and treatment represents a high economic impact، وبالتالي لازم نبص للرول of genomics in risk assessment which could be more cost effective. أنا هنا هركز على الموست aggressive category of breast cancer اللي هم التريبل نيجاتيف with breast cancer BRCA gene mutation. والحقيقه احنا الاديشن بتاعت 2003 احنا عرفنا منها معلومات كتيره قوي ريليفنت لكل الكانسرز. عرفنا ان في EGFR ميوتيشن في الادينوكارسينوما اوف ذا لونج، عرفنا ان في كيراس ميوتيشن في الكولوريكتال كانسر، عرفنا ان في APC ميوتيشن برضو في الكولوريكتال كانسر، في BRAF ميوتيشن في البيلانوما. كل دي information that we got from the human genome sequencing في 2003. وبالتالي it paved the way for drug discoveries and targeted therapies for these diseases. اللي يهمني هنا اني اركز على المعلومات اللي خدناها من الهيومن جينوم at that time. الحقيقه بين لنا ان في specific genes large genes responsible for hereditary cancers زي ال APC في الكولوريكتال كانسر، زي المجموعة بتاعت اللينش ال MSH ال PMS2 ال MLH، ودول وظيفتهم الريبير. وكذلك البراكا 1 والبراكا 2 وظيفتهم to repair ايه؟ احنا along our life, along our day we are exposed to insults and invasions and substances and environment that causes damage to our genes. And the function of these genes is to repair any damage occurring to our human genome. Of course, كل مجموعة منهم are inherent to repair in certain organ. يعني ال APC وظيفته to repair في الكولوريكتال في الكولون. ال MLH وال MSH مجموعة دي برضو repair any error occurring في ال right colon. ال BRCA genes are concerned with repair in genital organs، يعني البريست، الأوفري، البروستات. الحقيقة الجينز البراكا 1 والبراكا 2 جينز دول موجودين، عرفنا برضو الهيومن جينوم اديشن 2003 قالت لنا ان البراكا 1 موجود على الكروموزوم 17 والبراكا 2 موجود على الكروموزوم 13. طب وظيفتهم ازاي؟ how they do the repair؟ احنا قلنا we are exposed to invasions all the time and these invasions cause damage double strand breaks in our normal genes. طيب لو البراكا جين lost its function by being altered أو mutant، إيه اللي هيحصل؟ It will lose its function. Losing its function هنلاقي this cell في أحد احتمالين، يا إما this cell with this damage will die and this is very good، or الاحتمال الثاني والذي لا نرغبه إن جين تاني صغير not capable of proper repair اسمه البارب جين، بيطلع انزيم كده اسمه البارب، فالبارب يتفلسف ويقول انا اقدر اصلح. الحقيقه البارب cannot repair double strand break، هو كل اللي يقدر يعمله يحط بيز مثلا او سنجل ستراند بريك. الحقيقه ده erroneous repair. Erroneous repair will lead to genomic instability and will lead that this cell will undergo malignant transformation. ولذلك patients who lose their BRCA gene they are liable to develop breast cancer لأن في erroneous repair and development of malignant cell with the accumulation of genomic instability etc. طيب احنا اتعلمنا الحقيقة، طب احنا ازاي عرفنا البارب جينز بيعمل ايه؟ الحقيقة احنا استفدنا من التجربة بتاعت البلاتينم. البلاتينم احنا قلنا ان في الحالات دي هي اللي عندهم altered او loss of function of BRCA gene they are sensitive to platinum therapy. البلاتينم بيعمل ايه؟ بيجي عند دبل ستراندز ويروح حاطط adducts، يعني وبالتالي البارب cannot integrate here، يعني it blocks الفانكشن بتاعت البارب. فقالوا الله، طب ما احنا بدل البلاتينم والسايد افكتس يعني الكيموثيرابي سايد افكتس اوف ذا بلاتينم ثيرابي، طب we developed drug that can block or inhibit this PARP. وبالتالي they developed the PARP inhibitors. PARP inhibitors بقى بالرينج بتاعهم كله اللي انتوا عارفينه، اولاباريب ونيروكاباريب ونيراباريب اتسترا. ومن هنا جت النوشن او البرنسبل of tumor selective synthetic lethality. PARP inhibited with loss of function of BRCA gene يبقى the cell will die. إنما any of them is present the cell will survive. طيب البراكا جين بيعمل الكلام ده لوحده؟ الحقيقة البراكا جين ده long very long gene وما بيعملش الكلام ده لوحده. الحقيقة هو بيعمله in cooperation with many other genes. يعني هو هب الحقيقة وبيتعاون مع جينز كتيرة قوي علشان تفلفل الفانكشن اوف دبل ستراند بريك. اي ايرور بيحصل at these side of contact بتاعت البراكا جين هو ليه two ends. التو ends دول are very important لان هم دول السايت اوف كونتاكت with other homologous repair genes. فهو يعني الكونتاكت سايت اوف كونتاكتس دي بتعمل cooperation between the BRCA and the other genes in order to fulfill its repairing function. طيب لو حصل mutation at any site هنا الحقيقة مش هتحصل حاجة، برضه هتبقى benign إلا إذا جت في ال two ends of contact with other genes. مين هم ال other genes دول؟ المجموعة بتاعت الهومولوجس ريبير جينز ال ATM وال ATR والرات 51 والكلام ده كله. ولذلك نلاقي عند بعض الناس البراكا جين موجود ولكن أعوانه ما بيشتغلوش، وده اللي بنسميه البراكانس. يعني one of these genes with which BRCA gene cooperates is not functioning. فالبراكا جين ما يبقاش قادر ان هو. طيب البراكا جينز is a very long gene زي ما قلنا، في two sites اللي هم السايتس of contact with other genes، ولذلك معروف فيها more than 3000 mutations. انما هل كلهم في these sites في these sensitive sites؟ لا الحقيقة هم معظمهم في الوسط، يعني they do not affect the function, repairing function of BRCA gene. إنما those who are at the sites of contact of BRCA gene with other genes are the more pathogenic mutations. إحنا في اللاب لما بنعمل sequencing لبراكا جين لعيانة triple negative عندها family history young age هرمون ريسبتور نيجاتيف، طب تريبل نيجاتيف طبعا، فبنشوف السيكونس، بنلاقي السيكونس يا اما باثوجينيك يا اما نوت باثوجينيك بيناين، يعني ما هوش في السايتس اوف كونتاكت وذ اذر جينز. طب بنفقد الامل؟ لا مش بنفقد الامل الحقيقه. طيب بعد كده بنلاقي بعض الميوتيشنز ان بتوين، ولا هي باثوجينيك ولا هي بناين، ودول بنسميهم او يعني اعترف على انهم يعني mutations of conflicting evidence of pathogenicity او variants of unknown significance. الحقيقه احنا we report them برضو، لان with the accumulation of data وبندي، احنا بنشتغل في الكلاود، لان اي mutation we submit، يعني السيكونسر بيشتغلوا كده we submit our results to the cloud، وبنسبميت اي mutation whatever VUS or pathogenic or benign برضو، ومعاها الفاميلي هيستوري. ليه؟ لأنه with the accumulation of data these VUS can be reclassified into either benign or malignant. طيب برضو احنا اتكلمنا عن كاتيجوري قليله قوي اللي هم التريبل نيجاتيف. طب امال الباقي؟ احنا الباقي يعني how to assess the risk to breast cancer. The question arising طبعا what about the risk of breast cancer in the general population؟ واحنا عارفين طبعا prediction of disease risk is an essential part of preventive medicine. فهل في role for genomics towards improving population, general population estimates of women's breast cancer genetic risk؟ أنا قلت في الأول إن الهيومن جينوم الإديشن 2003 عرفنا منها اللارج جينز اللي هم عرفنا منهم البايوماركرز واللي هم بروموتد دراج ديسكفري لسيفرال مالجنسيز. إنما الإديشن بقى بتاع 22 دي بقى ال8% اللي ما كانوش ريدابل سنة 2003 became readable now في 2022 في الإديشن 2022. والحقيقة دول proved important for structural and medical reasons لأن they applied newer revolutionary methods for DNA sequencing and applied better computational approaches that set truly complete sequence of the human genome 2022. عرفنا منه إيه بقى؟ عرفنا وفجأة لقينا في النيتشر لقينا بيبر في 2022 على طول بتقول assessment of polygenic architecture and risk prediction based on common variants across 14 cancers. احنا هنا بيهمنا طبعا البريست كانسر ودي اللي سموها البوليجينيك ريسك سكور. يعني ايه polygenic risk score؟ Polygenic risk score is explained by the contributions of many small SNPs على الهيومن جينوم بتاعنا كلنا. SNPs of minor allele frequency يعني موجودة في النورمال. السنيب ده benign polymorphism single base single nucleotide موجود بالفريكونسي of less than 1% في النورمال population. These SNPs when they are categorized and calculated لقوهم كتير في الناس اللي هم at risk of breast cancer. أنا بتكلم على البريست مش other malignancies. طب عرفوهم إزاي؟ عرفوهم بحاجة اسمها الوايد جينوم أسوسيشن ستاديز. يعني إيه وايد جينوم أسوسيشن ستاديز؟ يعني إحنا لما بنعمل sequencing to the our population في اللي عنده بريست كانسر واللي عنده كارديوفاسكولار ديزيز واللي عنده دايابيتس ميليتس واللي عنده الزهايمر. كل الناس دي لما يتعمل لها sequencing and we compare the presence of these SNPs present on certain people with Alzheimer for example or with breast cancer and compare it to the normal population دي اسمها wide genome association studies that categorizes and identifies architecture معين موجود on the human genome of each of us and denotes its susceptibility أو vulnerability to a certain disease. معلش يمكن الكلام ده صعب شوية ولكن يمكن اللي جاي هيوضحه. All individuals have DNA risk in the form of SNPs for all common diseases. Usually السنبس دول are minor مش موجودين في النورمال population إلا بنسب أقل من 1%. Each person has a distinct combination of SNPs that contribute to the polygenic risk score of a certain disease. Quantifying these specific SNPs and their cumulative burden impacts on genetic susceptibility and disease occurrence. الجينوم وايد association studies اللي أنا قلت عليها يعني بنعمل sequencing to the whole population عيانين على normal على to identify these SNPs relevant to each disease. It provided data about numerous loci and the pathways that cause diseases and can be used for disease risk prediction. These loci are associated with a range of complex human traits and diseases, including cardiovascular, cancer, obesity, and Alzheimer. البيكتشر دي بتقول لك ده الهيومن جينوم. On the right side اللي عرفناه من الهيومن جينوم زمان اللارج جينز اللي احنا developed يعني targeted therapies، وكانوا يعني يعني invention of drugs يعني targeted therapies ودrugs طبعا against these large the alteration of these large genes. انما on the left دول الفاريانس اللي هم very rare. فشايفين لو الفاريانس دي are low قليلين قوي، يبقى the risk or the risk score for a certain disease is minimal or nil. If they are increased, there is a risk score or polygenic risk score for a certain disease. ودي الطريقة اللي حسبوا بيها البوليجينيك ريسك سكور. طيب what about breast cancer؟ specifically for breast cancer في 300 SNPs small single nucleotides have been identified وanalyzed وموجودين في اليو كي بايو بانك، و they serve as common susceptibility variants which are efficiently combined into a polygenic risk score. يعني أي ست هناك في إنجلترا عملت لنفسها سيكونسينج بتروح للبايو بانك تقول له أدي الداتا بتاعتي، قول لي الريسك بتاعتي to develop breast cancer قد إيه. تمام؟ طيب a higher SNPs burden is indicative of an elevated breast cancer risk. Integration of genomics for risk stratification of breast cancer into routine clinical practice should be considered. يبقى الهيومن جينوم داتا ادانا information about ايه؟ The alterations of large genes to which we have developed targeted therapies، وبرضو ادانا information about polygenic risk scores for many non-communicable diseases اللي هم diabetes, cardiovascular, breast, etc. إذن polygenic risk score calculation, introducing genomic information into risk models في UK Biobank will indicate the risk of this female to breast cancer. By quantifying the aggregating effect of these SNPs, we obtain an estimate of an individual's genetic risk for some trait. The total number of SNPs variants that a woman has indicates her heritable risk of developing a breast cancer disease. يعني polygenic risk scores has a potential for improving population estimates of women breast cancer genetic risk. طيب هل أنا أو حد من مصر راح اليو كي بايو بانك علشان يقول له أنا أدي الداتا بتاعتي، أدي السيكونسي بتاع ماي جينوم، ممكن تقول لي الريسك بتاعتي تو بريست كانسر قد إيه؟ هيقول لي سوري، لأن polygenic risk score is ethnic specific and population specific. روحوا عندكم في مصر اعملوا الوايت جينوم اسوسيشن ستاديز طالما انكم بتعملوا هول جينوم سيكونسينج علشان تعرفوا البوليجينيك ريسك سكور فور بريست كانسر قد ايه. يعني البوليجينيك ريسك سكور كومباريتور evaluates polygenic risk score of a certain population and compares it ممكن with worldwide population, and it categorizes population by disease risk and genetic vulnerabilities to diseases, and it is designed to be useful tool for public health decision making طبعا. Quantifying these SNPs في الهول population هيبين لنا مين هم الناس individuals who have higher SNPs than the normal control، وبالتالي نقدر نشوف deviation of the population towards high genetic risk أو towards low genetic risk of breast cancer. يبقى deciphering الهيومن جينوم داتا Deciphering the human genome data, it became increasingly important to include genomic information into risk models and bioinformatic tools. Recently, genomic data lead to development of polygenic risk score for prediction of many complex diseases زي ما قلنا cardiovascular, diabetes, cancer, and neurogenic. And prediction of disease risk is an essential part of preventive medicine and guiding clinical management. لو عرفنا ان during the journey of breast cancer treatment العيانه بتتكلف قد ايه؟ العيانه بتتكلف ده الريجستريز بتاعتنا $46,000. لو احنا صرفنا يعني 1% of this budget على ال identification of risk score of Egyptian women to breast cancer to assess their genetic risk to breast cancer, متهيألي ان يعني ده هيكون افضل، لان بالرغم من اللي بنصرفه لحد دلوقتي على المانجمنت والتريتمنت والدايجنوسيس والكلام ده، احنا برضو عندنا 11% mortality rate. This is the take home message. It would be important to include polygenic risk score in advance and enabling effective risk stratification of population-wide breast cancer screening and prevention strategies. Polygenic risk score is most predictive for identifying women at high risk when incorporated with other classic risk factors as family history. Polygenic risk score has been developed in populations of predominantly European genetic ancestry. احنا لازم نعمل our homework. These findings are also addressed to responsible of the Egyptian Human Genome Project to extract sufficient data in view of building polygenic risk scores for complex and heritable diseases. This information may be of benefit to Egypt's health and policy decision maker. Thank you very much.
Thank you so much, Dr. Wahab, for this very comprehensive and very elegant lecture.
ومعقدة شوية؟
يعني الجينومكس عموما صعب. تفضل دكتور أيمن، ولو كنا عايزين نأجل الدسكشن للآخر، بس طبعا تفضل يا فندم.
I have just clarification. يعني we can do the OncoTab DX outside, as you know. Why we can't do the polygenic risk outside?
لأنها الجينيتيك architecture is specific to each ethnicity and population.
طب the same applies for risk score. The same applied for OncoTab DX. The same concept is applied for the OncoTab DX and other genomic tests. Why the polygenic by itself is not applicable?
large genes يعني مثلا احنا عندنا الEGFR mutation في الادينوكارسينوما من 20 ل 25%، انما في الفار ايست 40%.
يعني التكنيك بيفرق يعني الستيب وايز بتفرق، ولا هو نفس الرياجنتس ولا او نفس لو كان جينيتيك هو نفس الطريق البي سي ار؟
اللارج جينز الديتكشن اوف لارج جينز والجينوميك ماب بتاعت اللارج جينز خلاص دي استابليشد من زمان، وخلاص عرفنا يعني اتعرفت، واحنا ويوز طبعا الانفورميشن من بره. يعني احنا عرفنا ان في EGFR ميوتيشن من بره، يعني قريناه، عرفنا ان في BRCA ميوتيشن برضو قريناه. الداتا بيز بتقول لنا ان الميوتيشنز كذا وكذا وكذا، وين كونسلت الداتا بيز ونلاقي ميوتيشن دي نقول يس ذيس ميوتيشن از بريزنت ومعروفه. ولكن يعني مثلا في ال 500 حاله اللي احنا عملناهم في مصر في بريست كانسر، 500 حاله بريست، لقينا ان ودي انفورميشن طبعا هي ان بابليكيشن 70% هاف BRCA جين ميوتيشن. كويس؟ BRCA في 3 نوفل ميوتيشنز مش موصوفين بره مثلا. اذا في اختلاف، اكيد في اختلاف فيما يخص اللو فريكونسي الليلز دي. دول سنيبس صغيرين جدا، سنجل نيوكليوتايد بوليمورفيزم، دول سكاترد على الهيومن جينوم بفريكونسي قليله جدا في النورمال less than 1%. انما they're gathering and they're if they are their size and their number is increased in a certain patient, يبقى ده denotes his liability to a specific disease.
Thank you.
Thank you so much Dr. Ayman. Thank you Dr. وفاء so much. اتفضلي يا دكتورة هبة، اتفضلي طبعا.
يعني sometimes اتفضلي يا دكتور عفا. sometimes بيبقى في حاجة مهمة جدا يمكن أهم من الوقت عشان كل الناس يعني very respectable people are there. طبعا يا دكتورة وفاء بنشكرك جدا جدا جدا، ودي يعني فكرة هايلة. ده لو دكتورة وفاء حطت بس 2-3 كيرف هي بتدعونا قوموا تيست يور سيلف، قوموا البوبوليشن حتى الصغيرة اللي عندها مامتها تريبل نيجاتيف، يعني هي نورمال بيرسون هتحط على البانكينج ده لو زيلت هذه اللي بتاع 2 this is a Nobel lecture، دي يعني حصول على جائزة نوبل يعني
ليه بقى في امريكا دلوقتي بيعملوا categorize patients breast cancer patients with their polygenic risk score، يعني ليه بقى؟ عشان يعملوا لهم كيمو بريفنشن فور بريفنشن، اما هرمونال او كيمو بريفنشن. فالحقيقه بالظبط
ال WHO في الريبورت بتاعها 2000 حاجه ريليتد جدا، بس اللي بيقرا وبيجمع بين السطور. ال WHO في الريبورت بتاعها 2022 بتقول because of prevention and the uncoding of the human genome and هنجيب مجموعة من الناس نديها very high prevention to get cancer colon cancer or breast cancer، هيزداد عدد الناس الادفانسد metastatic in developing country، والعالم كله هيقابل في ال developing country uncured cases يدفعوا عليهم فلوس كتير. فالريبورت ده بيصحينا ان مش هتبقى القصه كده، احنا اصلا يعني عندنا انهيارات في ايكونومكس كتيره، كمان هيبقى في الهيلث كير بتاع البريست كانسر او الكانسر. فهو ده الارم لينا ان قوموا شوفوا مين اللي هيجيله بريست ومين اللي هيجيله، ان ممكن نساعده لا اما ايرلي ديتكشن حتى نشوفه في مرحله بدري نقوم يبقى كيور او بريفنشن.
شكرا يا دكتوره هبه. الحقيقه يعني يا ريت لو تقروا على البوليجينيك ريسك سكور، مش بس في الكانسر على فكره، في ديزيزز تانية كتير.
الحقيقة I'm honored to be invited here today. Thank you so much Dr. Amani for inviting me for this very important annual conference. وهو طبعا أهم conference دلوقتي بيتكلم عن breast cancer في مصر الحقيقة، احنا بنستفيد منه كتير. Now I'm honored to introduce my dear colleague Dr. Ala Khurshid, Professor of Medical Oncology and Head of Department of Medical Oncology at National Cancer Institute, talking about that very debatable title, which is what's the next step in management of early triple negative breast cancer. تفضلي دكتورة.
Well, thank you very much for the kind introduction. And I want to thank Dr. Amani and congratulate her for the excellent positioning of Bahia Breast Cancer Congress and everything that she did in order to elevate the practice, especially in breast cancer. Thank you for inviting me, and it's an honor to be here. And it's an honor to last year I was discussing the triple negative breast cancer and early stage disease. And it's amazing how the practice has changed and how we're truly able to fine-tune the treatment on monthly basis and improve the survival. So just a quick reminder why triple negative is important, because 15% of our patients are triple negative. They're mainly young. And as Dr. Wafat said, 20% of them are going to be BRCA positive. They're heterogeneous. The problem with the early triple negative is that when they metastasize, first of all, they metastasize early, and they have a high risk of metastasis. And when they metastasize, it's typically visceral and brain. And when they metastasize, the 2-year overall survival is quite low, with less than 2-year overall survival after metastasis. So how do we compare it with other breast cancer subtypes? Even if you look at stage 1 disease, triple negative stage 1 disease patients are doing worse than patients with other subtypes. Stage 2 disease, stage 3. So we're in every subtype, when compared to other subtypes, in every stage there is a significant deterioration in the 5-year overall survival. So it's an unmet need in this disease to treat it, to achieve responses, and to achieve long disease-free and overall survival, because we don't want it to metastasize. Now, deep diving into the stage 1 disease. If you look at stage 1 disease, the T1N0, well, those patients without chemotherapy, they are not doing well. So you're improving the survival of the patients in the T1N0 disease. However, if you have a patient with a T1A or T1B, probably those patients will not need the adjuvant chemotherapy as you would like for the T1C. T1B, they still need, and the guidelines, as I will show you in a second, is showing that if you have a patient with stage 1A disease or T1B clinical, you can go for surgery, and then you will substratify the patient according if it was A or B, and for those patients, you will give, for 1A, no need for adjuvant chemotherapy, but if you have 1B or a pathological T1C, you have to give adjuvant chemotherapy. And if you have a clinical stage T1C, it is no longer allowed to go for surgery and chemotherapy. You now have to go for neoadjuvant treatment. Why is that? Because basically, if you look at stage 2 disease and stage 3, if you do surgery and then give the adjuvant chemotherapy that we give for our patients, you're going to lose 25% of your patients in stage 2 disease at 5 years. And for your stage 3 disease, actually you're going to lose 70% of your patients. So this is why we no longer go for upfront surgery. We give neoadjuvant treatment for any any patient with a stage that is 2 to 3. The aim is to achieve a pathological CR, because we know when we achieve a pathological CR, we are improving the disease-free and overall survival. So this is a patient, stage 3 disease, who underwent neoadjuvant treatment, achieved the pathological CR, and you can clearly see the difference in survival of this patient. 5-year event-free survival is approaching 90% when patients achieve pathological CR. If they don't achieve a pathological CR, even if they were a stage 2 disease, the median survival is still low, over 9 months compared to 20 months. Then after surgery, we have the option of fine-tuning our treatment, giving individualized treatment, which is based on the response of treatment. So the roadmap of treatment of triple-negative breast cancer has changed from surgery and then chemotherapy to now going for neoadjuvant treatment. The neoadjuvant is based on the stage of the disease, and then when the patient, you look at the pathological CR of the patient, and according to the pathological CR, you choose your treatment. So it's important to achieve pathological CR, and we know that pathological CR has improved with anthracyclines. That was only 20%, and then when we added taxanes, it went to 30%, and when platinum was added, it went up to 53%. We've known that from all the trials that have added platinums. Again, this is improving the event-free survival by 7% just by adding the platinum and just by improving the pathological CR. However, it's important to know that you should use platinum only for your patients who are younger than the age of 50. We've seen in the Indian TMC trial that patients more than 50, they did not really benefit. And for those who have achieved a pathological CR and they were younger than the age of 50, they did have a significant improvement in the event-free and overall survival. Now, should we add platinum only based on BRCA mutation? And the answer is no. You add platinum regardless of the BRCA status. Because even in the wild BRCA, you can see a significant improvement in the pathological CR for triple-negative patients. Now, we understood better that triple-negative disease is guided by and it is driven by a lot of other factors, such as the immune-rich and the DNA repair pathway that was just explained. So how can we use these drugs in order to improve the pathological CR? And we started to have trials that are incorporating IOs in the neoadjuvant and adjuvant setting. So in the neoadjuvant setting alone, before surgery, we have 2 trials, or we give it before and after surgery, and we have 3 trials, and or should we just give the adjuvant IO? Is it advisable to give adjuvant IO for those patients who went for surgery, and will they still benefit from the adjuvant IO? So the practice-changing clinical trial that you have all heard, I'm sure it has been repeated a lot of times in this Congress, is the Keynote 522 trial. This is a trial that randomized patients with a stage 2 or 3 disease, triple-negative breast cancer, to giving these patients the 12 weeks of carboplatin and paclitaxel, followed by the 12 weeks of the 4 cycles of doxorubicin and epirubicin, with or without pembrolizumab. And for those patients who received the pembrolizumab before surgery, they were given continued 1 year of pembrolizumab, so 9 more cycles of pembrolizumab. The primary endpoint for this trial was pathological CR and the event-free survival. And you can see that the pathological CR was significantly increased when the pembrolizumab was added to the chemotherapy. So with our best treatment, we achieve 50%. Now, when you add pembrolizumab, you can have a 65% pathological CR, a 13.6% difference, and this is seen regardless of the PD-L1 expression. Now, it's important to note that for patients who have a higher PD-L1 expression, they really do well with chemotherapy. You will see that the pathological CR rises with the higher PD-L1 expression. Despite that, patients, regardless of the PD-L1 expression, they will have a significant improvement in their PCR. And this translated to an improvement in the event-free survival. We have the 5-year event-free survival that is 10% higher, with a hazard ratio of 0.63, with a risk reduction of 47% when you add pembrolizumab for your patient. And this is seen regardless of the PD-L1 expression, regardless of the stage, regardless of whether or not the patient had a node-negative disease, and regardless of whether the patient had a T2 disease. It's a 9% improvement in the disease-free survival. And now, just reported in the last ESMO is the 5-year overall survival. This was something that we were all waiting for. Adding pembrolizumab increases the 5-year, after a median follow-up of 75 months, increases the 5-year overall survival by 5%, decreases the risk of death by 44%, and this is seen again across all subtypes. Now, is the benefit from the Keynote 522 just driven by the fact that it is leading to pathological CR? Well, again, if the patients are achieving pathological CR, they are doing great, even if they were a stage 3 disease. And if they're a stage 3 disease and achieve the pathological CR, you can see that at our 75-month follow-up, the 5-year survival was 95%. However, if they don't achieve a pathological CR, and we know that this is a problem for our patients, they still drive benefit by being given the pembro, being given the pembro in the neoadjuvant and in the adjuvant arm. Now, the question is, do we need to give adjuvant treatment for all our patients? And if you look, and this is really based on the residual cancer burden, if you have a patient with a residual cancer burden 2, for example, there is a significant improvement in the survival if the patient received pembrolizumab. Yet if the patient had a residual cancer burden of only 1, maybe those patients are not going to need to receive the pembrolizumab. You can see that there's no difference in survival. And if the patient had a residual cancer burden 3, actually getting the pembro is maybe not, those patients are not going to do fine. And maybe for those patients, we need to think differently. Maybe we shouldn't give IOs, or if we give IO, we need to add something else with them. And then comes the question, can we de-escalate the pembro in the adjuvant setting? So we are in Egypt. It's quite expensive to give immune checkpoint inhibitors. We have this very important debate now. Can we include the pembro in the triple negative? We can, we should. But how long should we give it? So, based on the pathological CR, if a patient achieves a pathological CR, we've known for the Keynote trial that patients achieving pathological CR, they are doing excellent. Now, in the GEPER-NEVO trial, this was a trial that gave IO only in the neoadjuvant setting, no IO in the adjuvant setting. And in this trial, there was a significant improvement in the disease-free and overall survival, despite the fact, because in this trial, they didn't include anthracyclines, and it was mainly durva and nab-paclitaxel and nab-paclitaxel. They didn't include carboplatin in this trial. I'm sorry, they didn't include carboplatin, they included anthracyclines, yet there was an improvement in the survival. So now we have two trials that are asking this question: do we need to give pembro in the adjuvant setting or not? The OPT-PEMBRO and the optimized PCR trials. And then question to all of us: if the patient didn't receive neoadjuvant IO, should they receive IO as adjuvant setting? And the answer is no. If the patient didn't receive neoadjuvant IO, please do not give IO in the adjuvant setting. You can see in the Alexandria Impassioned 030 trial, where they gave patients who underwent surgery, received chemotherapy, and then were randomized to chemo with or without immunotherapy, atezolizumab, and there was no difference in survival, as you can see. So if I'm going to give immune checkpoint inhibitor, it's only in the neoadjuvant and adjuvant setting. I cannot give it in the adjuvant setting alone. And then this is quite a regimen. You give a lot of protocols in it. Do we need to give anthracyclines? It's a bit toxic. We've known from the NeoSTOP trial that we can actually substitute. We know that giving taxanes and carboplatin is equivalent in disease-free and overall survival and pathological CR to regimens that are including anthracyclines. And so anthracyclines are not really mandated. And we have the NeoPACT trial, which is a small trial that eliminated anthracyclines, and it gave pembrolizumab, docetaxel, carboplatin in 120 patients. Pathological CR was 60%, and you can see a significant improvement in event-free survival. And now we're waiting for the SCARLET trial, which is really asking this question: do we need to add anthracyclines or not? So this is something that we will be waiting for. It's a trial that will include 2,400 patients. And then finally, ADCs in the neoadjuvant setting. We've seen that sacituzumab govitecan has been shown to improve the pathological CR, and even the Dato-DXd in first-line metastatic disease, it is really associated with very good objective responses. And now we have two trials that are looking at adding the ADCs to IOs and perhaps replacing completely the preoperative chemotherapy arm. PARP inhibitors, we know how important it is, and we've seen trials, small trials, that does show that talazoparib, for example, you can have a pathological CR of 63%. However, if you compare it to platinum, it's not really showing a difference in pathological CR in this small trial, and yet we're having an ongoing trial, the Olympia neoadjuvant trial, in stage 1 disease, which is looking at giving olaparib and durva in stage 2 tumors, or olaparib alone in stage 1 disease. Now, how can we improve the outcome? And again, a very important part of improving the outcome is the residual disease despite the neoadjuvant treatment. And if you have a residual disease, the survival is bad, you need to escalate your treatment, whether by chemotherapy, and we've seen with the capecitabine that adding capecitabine for those patients who receive neoadjuvant treatment and had the residual disease, you get an improvement in the progression-free and overall survival. We've seen this in the meta-analysis. And important to know that platinum is not superior to capecitabine. You can give either, but of course capecitabine is much easier. And what about giving immune checkpoint inhibitors? Again, I'm saying again, the ABRAVE trial was randomized in patients to receive adjuvant immune checkpoint inhibitor, and this trial was reported in the last ASCO to be negative. And then what about those patients who have a germinal BRCA mutation? And this is again another practice-changing trial, the olaparib Olympia trial, giving olaparib for 1 year for the BRCA-positive patients who have received neoadjuvant treatment and have a residual disease. Those patients, you will improve the 3-year disease-free survival and decrease the risk of death by 42%, and improve the overall survival at 4 years by 3.4%. And then comes the question, can we combine treatments? Because again, we are not happy with the results that we have with the residual disease. What about combining chemotherapy and IO? For example, giving pembro and capecitabine in patients who have a residual disease. And this is, again, we have trials that are looking that there is synergistic effects. And there seems to be an improvement in the survival in those small trials, phase 2 trials. I don't know what to do. ازاي اعمل exit? Okay. And then the other, and there are actually 2 trials that are ongoing, the Optimize RD, the Accent 05 trial, the Tropion 03 trial. Both trials are asking this question, shall I go for just, and actually those are questions asking, is ADC with IO better, or now they're using the control arm of IO with chemotherapy, is that a better? So now it's becoming a control arm. So it will be interesting to see the results of these trials. What are the guidelines saying? You can consider the combination, but this is, again, this is level evidence of 4. Maybe sequential or combined. We really don't, we need to see the data. What about combination with PARP inhibitors and IOs? We know that there's again synergistic effect with PARP inhibitors and immune checkpoint inhibitors. There are a lot of trials in the metastatic setting that triple negative, and there are phase 2 data that are showing that that are coming up and basically looking at, is it safe? Yes, it's safe. You're going to see more, a little bit of more pancytopenia. And if you look at the guidelines, again, the ESMO and the NCCN guidelines, if you have a BRCA mutated patient, you can consider olaparib and pembrolizumab. However, you do not consider olaparib and chemotherapy. Why is that? Because this combination is quite toxic. It's associated with really dose-limiting cytopenias. And finally, if I have a residual disease, can I give the ADCs, sacituzumab? For example, we have the SASIA trial. And we have actually now the trials that are looking at combinations with IOs. I just said that. And it's important to further identify those who are high risk. And the reason that this slide is put is that not all patients who are achieving pathological CR are not going to have a risk of recurrence. And even those patients who have a residual disease, not all of them are going to have 100% recurrence. And this is where circulating tumor DNA is important. And it's important to see that patients who have a circulating tumor DNA, they have a high risk of metastasis. And now these are the current clinical trials that are ongoing looking at that. So the today roadmap for treatment of early triple negative breast cancer has changed. If you have a T1A, B clinical, then it's surgery, followed by chemotherapy for T1B patients. If you have a T1C and 0 disease, the standard of care is neoadjuvant taxane, platinum, followed by surgery. And then if the patient achieves a pathological CR based on the BRCA mutated, you can give olaparib even in T1C disease for 1 year. And if the patient does achieve a pathological CR, no further treatment. If the patient has more than 2 centimeter disease or has any lymph node, then the neoadjuvant treatment, the keynote study, and the patient then achieve a pathological CR. The question is, do I continue the 1 year of pembro or can I stop the treatment? And if the patient doesn't achieve a pathological CR, whether to give pembro or olaparib or give a combination, as I just said. And whether we need to remove anthracyclines or maybe we need to give neoadjuvant PARP inhibitors or the ADCs, that's another question. This is the current ESMO guidelines, and this is a final note that survival of triple negative disease has truly improved after understanding the driving mutations and the driving forces for this disease. It's no longer not a targetable drug. You can see that olaparib and immune checkpoint inhibitors, they play a very important role. And it's important to know, and probably this is what's going to happen in triple negative, and hopefully by next year if they invite me and I give the same lecture, I will give the unmet needs and escalation and de-escalation. Maybe this will change. Thank you very much.
Thank you, Professor Ola, for this nice presentation. And I think we should keep the questions until the end of the session. So we have to move to the next speaker, Professor Amani Hilal, Professor of Medical Oncology, NCI, and the Head of Medical Oncology Department at Bahia Hospital, and the President of the Conference of Bahia. Please, Professor.
Thank you very much Professor شريف for the nice introduction. أشكركم جميعا طبعا انتوا لسه قاعدين لغايه دلوقتي، انا شخصيا مش عارفه انا قاعده ازاي لغايه دلوقتي، فشكرا جزيلا انكم مكملين معانا. انا هتكلم عن الاوبتمايزيشن وبوست نيو ادجوانت تريتمنت. I'm not going to talk about drugs لان انا عارفه ان كلنا عارفين drugs اكتر، يعني مش محتاجين نقولها تاني. I'm saying about how to بحركها ازاي؟ Okay. The current indications of neoadjuvant systemic treatment, factors for post-neoadjuvant treatment decision, PCR, and what's beyond PCR. This is the current the guidelines for the treatment of the breast cancer. As you can see, triple negative, you should start neoadjuvant starting from the T1C. HER2 neo positive, we should start for the tumor size more than 2 centimeters. So 2.1, we should start with the neoadjuvant. Even the luminant that we are talking about, they are not giving PCR as the others. Still, they increasing the indications for the neoadjuvant treatment for the group of patients. So what should we do after giving the neoadjuvant? We all know the advantages of the neoadjuvant, I'm not going to repeat, but what should we do after the neoadjuvant? How should we treat our patients after receiving and knowing the response of the treatment pathologically? We all using the PCR for the post-treatment the neoadjuvant now, and this is the pooled analysis showing that patients with the PCR doing much better than those who did not achieve the PCR for all subgroup of patients, although it's higher in the triple negative and HER2 neo enriched, but still has a prognostic impact even in the hormone receptor positive, particularly the luminal breast cancer patients. And this is the difference between the different subtypes. However, despite the pathological complete response, patients had the best prognosis as we are all thinking, but still the clinical factors that we are measuring our adjuvant treatment, like the lymph node positive or the size of the tumor, are still working within the BCR patients, are working more in the non-BCR patients. So patients with high risk factors before the treatment and did not achieve the BCR have the prognosis better than those who started with poor prognostic factors as the lymph node positivity or large tumor size or high Ki-67 or whatsoever. BCR is a very important or a very significant surrogate for the outcome on the patient level, meaning when doing the patient analysis, yes, every patient received had a BCR will have a better outcome, but when going to on the trial level, on the left side, the theoretical, you should, when you increasing the BCR, you should have an increase in the event-free survival and overall survival for all the trials in this linear subtype, but in the real life, the trials, as you can see, are distributed around the line, meaning that achieving BCR is not always associated with, or is not a sure sign that could be associated with a good outcome. Residual, are the challenges of using BCR as a neoadjuvant endpoint? While prognostic BCR status does not consistently predict individual outcome, 15% of patients with BCR experience disease relapse, as just said by Dr. Ola, and about 60% of patients with post-neoadjuvant residual disease never relapse. So we have to have better predictive markers needed, extend characteristics of residual tumor, availability of post-operative systemic therapy, patient demographics, and the blood biomarkers. Expected BCR differ markedly by the breast cancer subtype, so if you are using BCR very comfortably with the triple negative and HER2 neo positive, this is not suitable for patients with the hormone receptor positive, not proven that BCR improvement translates into trial level difference in the outcome, so BCR must therefore be considered in the context of totality of evidence of efficacy and safety. So it's not my job now to convince you not using BCR. No, my job is to use BCR with the context of other factors, and the group of the non-BCR that sometimes may be over-treated because they are just achieving the BCR. Even the disease patients presenting with the T1 mic, they are considered as not achieving BCR and subjected to an aggressive post-neoadjuvant treatment. That's now we all pathological reports are not coming with just BCR non-viable cells. Now we have a residual cancer burden depending on the residual invasive breast cancer, total tumor that is in situ, number of positive lymph nodes and largest nodal metastasis, and tumor cellularity, and the preoperative therapy. And we have 4 groups, 0, 1, 2, and 3, and they are found in the prospectively to have a very good prognostic impact. Patients with the residual cancer burden 0 have the the best outcome. They are having PCR, but again, the patients with the residual cancer burden 1 have a much better prognosis than those with the residual cancer burden 3. So why should we put all of them in the same basket, giving them the same treatment? The association of, as you can see, this is the association, and again, the highest association have been seen among the patients with the triple negative and HER2 positive rather than the hormone receptor positive. In the Keynote trial, they are trying to find what is the effect of adding pembrolizumab on the residual cancer burden. The adding pembrolizumab increasing the event-free survival in the patients with the residual cancer burden 2. This the group in the middle. They are not residual cancer burden 1 having very good prognosis and not the very bad prognostic patients. So the addition of pembrolizumab really added to the outcome of these patients. I'm not saying only to give the patients with the residual cancer burden, but it's an information that we can make a benefit of in the further trials. The other score that we now are using is the clinical prognostic, clinical pathological score, estrogen receptor grade score. This is a combination of using the stage, the pathological stage, clinical stage, and the estrogen receptor and grade, and they are scored from 0 to 6, and has been associated with a very good outcome. The score 1 to the score 0, 1, 2 differ markedly from the score 6. So again, we can use this score, and they used it in the Olympia trial for patients with hormone receptor positive who did not achieve the BCR, because they know that the BCR is not an enough prognostic factor among the patients with hormone receptor positive, and really it worked. Now, going to the tumor-infiltrating lymphocytes. We are speaking about the tumor-infiltrating lymphocytes for the long time. And I think I gave a lecture about 5 years ago, saying that tumor-infiltrating lymphocytes are very important prognostic factors, especially in the patients with triple negative and HER2 positive, although till now we are not including the tumor-infiltrating lymphocytes in our pathology reports, and we cannot make a clinical utility of these tumor-infiltrating lymphocytes, hoping to have to make benefit of them in the future. Okay. Not only detecting good prognosis, but the presence of the tumor-infiltrating lymphocytes can predict the patients who can achieve a pathological complete response. And this is mainly in the triple negative. As you can see here in this graph, they are using the low, intermediate, and the high tumor-infiltrating lymphocytes. And those with the high tumor-infiltrating lymphocytes achieved the highest, the pathological complete response. So now one not using this, the stromal tumor-infiltrating lymphocytes in the residual disease, taking the residual disease, measuring the tumor-infiltrating lymphocytes, and again it worked and showed that those with the high tumor-infiltrating lymphocytes having the best prognosis than those with the low. So we can spare patients with these good prognosis from the treatment, and the early trials of the HER2 positive were trying to detecting the patients of the high tumor-infiltrating lymphocytes that may not need anti-HER2, or we cannot need to add chemotherapy for these patients, but not yet used. These are all the trials that trying to detect the prognostic impact of the tumor-infiltrating lymphocytes in the residue after the neoadjuvant chemotherapy. More than 8,000 patients, increased immune infiltrate, meaning improved neoadjuvant response, improved prognosis in triple negative and HER2 positive. This is a high level of evidence with multiple clinical trial cohorts. This is the stromal tumor-infiltrating lymphocytes in the residual disease from Japan Nuvo trial. This used the neoadjuvant duravalumab for the patients with the triple negative, and surprisingly, these patients did not add significant improvement in the pathological complete response, but it improved significantly the event-free survival. And here again, detecting the tumor-infiltrating lymphocytes, high tumor-infiltrating lymphocytes carries the good prognosis. Trying to bind both the residual cancer burden with the tumor-infiltrating lymphocytes, and again, the highest evidence were detected among the patients with the residual cancer burden class 2. In the tumor-infiltrating lymphocytes in the different trials, even the level of which the patient has low or high is much different. Sometimes they are using 20%, 30%. One trial used 60% for the patients who are having a high TILS. So till now, we don't have an exact level above which we can consider the tumor has a high TILS or not. But still, it is the marker that we can use in the context of other factors. Ki-67, an excellent marker for determining the growth fraction of any given cell population. The clinical utility of Ki-67 till now is evident only in anatomically favorable ER-positive and HER2-negative patients. And at present, there is no clear consensus on the Ki-67 score that would differentiate patients at higher or lower risk. They are just saying that if you have a patient less than 5, this means that this patient has a very good prognosis, and those above 30 have poor prognosis. What about those between 5 and 30? We don't know. They are trying to make a use of the Ki-67 by measuring the tumor response to very short duration of the neoadjuvant hormonal treatment. And I think we have a trial in the NCI by Dr. Ayman and Dr. Aminat trying to give the patient the trial of only measuring the Ki-67 at the baseline, give 2 weeks of the endocrinal treatment, and then subjecting the patients to the surgery and measuring the Ki-67 at on the residual or the tumor. If the Ki-67 starting low and ending low, this is the best. And if the tumor is starting with high and turning low, this is good. But if the patient starts with the high Ki-67 and ending with high Ki-67, they have the worst prognosis. And this was the basis for the ADAPT trial, where the patients having the recurrence have the recurrence score at the biopsy and Ki-67, and then received 2 weeks of the neoadjuvant hormonal treatment and went to surgery. Those with the lymph node positive T, N2 and N3 received chemotherapy without any further detection of the KI. While those with the N0 to 1 recurrence score 12 to 25, that we are usually to the premenopausal patients giving these patients the chemotherapy with the Ki-67 post neoadjuvant less than 10, these patients were given endocrine treatment at those with the low risk 0 to 11. And they found that if you have a high score with the low Ki-67 after the neoadjuvant treatment, they are doing non-inferior to those with the low score. So binding 2 factors together give us the same prognostic impact of the of the very low recurrence score. This is the measuring Ki-67 measured after neoadjuvant chemotherapy. Those with the PCR have the best. However, those with the Ki-67 less than 15% still doing very well. But again, we don't have an exact level of the Ki-67, what should be considered low or high. Some trials using 10%, some trials using 15%, and others even using 20%, but we don't have still a very promising level of the Ki-67. Now going to the circulating DNA, and I think Professor Ola gave a mention for them. This is I think this is the future, the dynamic measurement of the response of the tumor. ودي أنا متغششها من دكتورة وفاء قبل ما أقول المحاضرة إن أنا أقول إن ctDNA this is the dynamic measurement of response to the neoadjuvant treatment, and they are very promising. Those patients who had ربنا أنتم بتعطلون أيوه أوكي. Circulating, this is the PCR with this from the 1SPY2 trial. The patients with PCR negative circulating DNA have the best prognosis, of course, but those even with non-PCR and negative circulating DNA have a good prognosis that differs much from those with the positive cDNA. So the non-PCR patients now, there are a difference of about 13% between both of them in the disease-free survival and in distant relapse-free disease-free survival. So this is an important, I think, biomarker that can be used for further defining the treatment options for patients after the neoadjuvant chemotherapy. And this again, in the Penelope trial, the patients received the post-neoadjuvant palbociclib and hormone treatment. It was a negative trial. But however, the use of the circulating DNA and the non-detected cDNA have much better the survival than those who had the circulating DNA detected with the same, as you can see, improvement in the invasive survival and distant disease-free survival. Now, HER2-GX-SE in patients with HER2-neu positive breast cancer, this is a standardized 27 gene expression that have been used for the prognostic impact in patients with early stage HER2-neu positive breast cancer. HER2-GX provide 2 scores from 0 to 100, BCR likelihood score, low versus medium versus high, and risk of relapse score, low versus high. Meaning if I want to use the score to predict the response to the neoadjuvant chemotherapy, I can stratify them into low, intermediate, and high, while when using for the prognostic impact of getting relapse or not, we are using the risk of low versus high. And this is the association of HER2-GX with PCR and survival outcomes in the HER2-neu positive breast cancer by the 2 trials in the neoadjuvant setting. And as you can see in the patients who achieved for the whole population, BCR is much different than the non-BCR. But if we are using the HER2-GX in the BCR population, still there is a difference. Those who had the high HER2-GX risk score from the beginning, they are measuring the risk from the before starting neoadjuvant, not on the residual disease like the other markers. They still have a better prognosis than those with high HER2-GX and non-BCR population. The difference is much more larger. It's about more than the 10%, increasing the improvement in the event-free survival for those with the low HER2-GX. In conclusion, patient-level BCR is a good news for the individual patient. Trial-level BCR is not an optimal surrogate endpoint for a clinical trial. The non-BCR group is a heterogeneous, challenging for post-neoadjuvant chemotherapy treatment decisions. Options for improvement is using whatever you have as a molecular biology, as improved staging by residual cancer burden, by additional parameters as the combining the prognostic factors together, molecular residual disease, or even using the HER2-GX score, also the molecular factors to stratify the non-BCR. And I think this is the problem, the non-BCR group, so can spare some of our patients from this intensive treatment. Thank you very much.
Thank you very much, Professor Amani, for this very comprehensive and very beneficial, not only for the presentation, but for the whole meeting, of course. And now we are moving to the next speaker, Professor Ahmed Al-Bastawisi, a professor of medical oncology at the National Cancer Institute and the medical consultant at Bahia Hospital. And Professor Ahmed is going to talk about the evolving role of ADCs in the management of brain metastasis. Please, Professor.
Thank you, Professor Hani Abdelaziz, for your kind introduction. So this is the outline of my presentation. I will start with a small introduction, and then I will divide my talk into HER2-positive advanced breast cancer and HER2-negative disease. So what we know about breast cancer brain mets, if we look at the incidence of brain mets in different malignancies, breast cancer is ranging from 7.6% up to 30%, putting breast cancer as the second most frequent malignancy after lung cancer by all its subdivisions regarding the incidence of brain mets. And what we know about breast cancer brain mets is that after improving the outcome of brain mets, we had increased survival and subsequently increasing incidence of occurrence of brain mets as the first occurrence of distant disease. And as you know, it is a very devastating complication. It increases the disease-related morbidity and mortality. And the optimal management is always not only focusing on the local treatment of brain mets, but controlling the extra and the intracranial disease. And the aim of systemic treatment was always to delay the incidence of brain mets or delay the incidence of local treatment like whole brain irradiation with all its complications. And unfortunately, not only in breast cancer, and in every malignancy, we had initially brain mets patients excluded from prospective randomized clinical trial, and then we moved to the era of, okay, let's incorporate patients who are having a stable brain mets without DEXA, and then stable brain mets. But now there is many clinical trials in different malignancies incorporating patients with brain mets. And as you know about ADCs, it is the new revolutionary wave in oncology, and you know that it is a form of antibody targeted to a molecularly highly expressed cancer cell, and a payload and a linker in between, and ideally the linker will not release the payload until reaching the malignant cell. And all you know about the mechanism of action by binding to the antigen, internalization, degradation of the ADC in the lysosome, and finally release of the payload, hoping to elicit apoptosis of malignant cells. And we hear about the bystander effect by releasing of the payload to the nearby cells. What we have of ADCs, we have more than 100 ADCs in clinical development in almost every malignancy. And if we look at breast cancer, we have HER2 and TROP2 as the most targeted antigens for breast cancer. We have the Pfizer ADC, which is TDM1 for HER2, and we have trastuzumab deruxtecan for HER2, sacituzumab govitecan for TROP2. All the three are already having regulatory approvals, whereas datopotamab deruxtecan is waiting for approval. Other targets under evaluation are HER3, Nectin-4, B7H3, B7H4, and the tissue factor, and the others. And what we know about brain mets in HER2-positive disease, we know that it is a very common occurrence in around half of patients, and it is a continuous over time. It can occur at any time, even after years of diagnosing metastatic disease. And as you know, the overall survival of HER2-positive metastatic breast cancer is much more improving, and subsequently we are encountered by more cases with brain mets. How to manage brain mets? We know that different parameters determine how to go for treatment, whether the patient received a prior treatment, the type of recurrence, prognosis, size, symptoms, resectability, previous treatments, and so on. But if we look at the definitions, which will be discussed in the next slides, in all the clinical trials, we define stable brain mets as patients who have received the prior CNS directed therapy for their brain mets, and the disease is stable. Whereas active mets are defined as either new brain mets or progressive brain mets that have not received CNS directed therapy since documentation. And the leptomeningeal disease is presence of metastasis in the leptomeningeal space as identified by CSF positivity or radiological and clinical data. So what did we do for HER2-positive metastatic brain mets? If we look at the Cleopatra trial, which was a very landmark trial, because when we added pertuzumab to docetaxel trastuzumab, we experienced the longest ever at that time median overall survival for metastatic breast cancer was around 5 years median overall survival. But if we look at the group of patients in Cleopatra who are having brain mets, look at the progression, look at the brain mets free survival or overall survival, the curves are favoring the use of pertuzumab added to trastuzumab, yes. But if we look at the incidence of CNS mets, it is around 15% in both arms, for the arm of pertuzumab and the arm of placebo. What I want to say is that, yes, the addition of pertuzumab improved the brain mets free survival and overall survival in patients who experienced brain mets, but it did not lead to decreased incidence of brain mets. What are other agents we had? We had TDM1 in Catherine trial, and it was a positive trial. We had a median follow-up of around 8.4, and if we look at the incidence of distant mets, we are having a fewer incidence of distant recurrence in favor of Catherine. But if we look at the incidence of CNS mets out of these distant mets, It is once again seems to be not reduced with the addition of the older or the father ADC, which is TDM1. So definitely what we have with large monoclonal antibodies, including even TDM1, is that we could improve the results in patients experiencing CNS mets, but we couldn't decrease the incidence of brain mets itself. What we have with small tyrosine kinase inhibitors, if we look at tucatinib, and this is the HER2CLIMB, and the HER2CLIMB trial is very important clinical trial. Why? Because it included at least 50% of patients having brain mets at baseline. And out of these 50% patients with brain mets, we have 60% patients with active brain mets. So HER2CLIMB was a very good trial to answer the issue of brain mets, including active disease. And if we look at CNS, PFS, and OS, the curves are in favor of the addition of tucatinib. And if we look at the intracranial overall response rate, 47.3 versus only 20%, more than doubled. And if we look at these results, we clearly can put tucatinib in a very prestigious place in the treatment of patients with active brain mets having HER2 disease. And this is why it is the first line in patients having active brain mets. What we have with ADCs, if we look at the data, we have, this is Camellia trial, which was a phase 3b trial for TDM1 in pre-treated patients. And they look at the right side of the screen where we have some responses, but look at the bottom for patients not receiving prior radiotherapy, which means that these are the patients who are tested for the efficacy of systemic treatment as TDM1. And if we look at the response rate, it is in the range of 50%. Very good response, which simply means that we can control the systemic disease, we can control the brain mets with systemic treatment only. And as you know, multiplicity of lines in the systemic, in the metastatic disease led to disruption of the blood-brain barrier, and it was replaced by what is called the blood tumor barrier at the metastatic site. And what we also know is that TDXD is pharmacologically superior to the father TDM1 because we have a very potent payload, which is SN38, which is 20 times having a larger potency than irinotecan. Again, we have a very large drug to antibody ratio as compared to TDM1, and a cleavable linker as compared to a stable one for TDM1. What does this mean? Look at the action of ADC at the blood tumor barrier when the drug is internalized into the malignant cell and lysosome, and the release of the drug. If you are having an agent with a higher drug to antibody ratio, so we will have much more drug to be released to the nearby cells, and this is why we can have a bystander effect in favor of the drug having more drug to antibody ratio. And this is TDXD. And if we look at the results for TDXD in patients with active brain mets, these are the data we have. If we look at Tuxedo-1 incorporating patients with active brain mets, we have a response rate of around 73%, very good. Again, in DEBRA trial, we have around 50% response rate. Once again, in MD Anderson Duke analysis, we have around 73%. So we have a reasonable response regarding the use of TDXD in patients with active brain mets. Again, if we look at data from a joint analysis of Destiny Breast 1, 2, 3, which initially, before amendment, included patients with symptomatic untreated brain mets, and this is one of the exceptions in oncology in which we add these populations in clinical trials. So look at the results. We have intracranial overall response of around 45.2 and 45.5 respectively, regardless of activity, as compared to the comparator of around 24 and 12. Very good results. Again, if we look at the progression-free survival for either treated stable or untreated active brain mets, both conditions, we have good results for TDXD and brain mets. Again, more importantly, because the quality of life in this population is very crucial. We have disease control with maintaining a quality of life regarding global health status and the physical functioning, emotional functioning, and more importantly, cognitive functioning. And compared to radiotherapy, because if you are receiving whole cranial irradiation in a patient with improved intracranial and extracranial survival with the new agents, so the patient is more liable to cognitive functioning deterioration and all the adverse events of local treatment. So if you can control the brain mets with only systemic treatment, avoiding the adverse events of radiotherapy, it is very good. But perhaps the improvement in brain mets in HER2-positive advanced breast cancer didn't occur until 1 month ago in the last ESMO, when the dramatic results of Destiny Breast 2 was presented. And this Destiny Breast 2 was a phase 3/4 multi-center single-arm 2-cohort study. It was assessing patients with treated HER2-positive metastatic breast cancer with and without brain mets, and it is the largest prospective study for TDXD in patients with stable or active disease. So 2 cohorts. The first cohort is baseline brain mets, as the definitions I just elicited, and the second cohort are no baseline brain mets, both of which will receive TDXD, and the primary endpoint for the first cohort is BFS, and for the second cohort is overall response rate. And if we look at the patient disposition, we have around 157 stable disease and the active brain mets around 39, and previously treated 67, very good numbers. And if we look at no baseline brain mets, around 241, and the median follow-up was 15 and 16 months respectively in both arms. So a very good inclusion criteria to assess the disease. And if we look at the demographics and the baseline characteristics, we have the majority of patients receiving 1 or 2 lines previously, and the vast majority received trastuzumab followed by pertuzumab for metastatic disease, and they look at the results. Fortunately, the primary endpoint of progression-free survival was met, and we have a 12-month PFS of around 61.6 in the overall population, in stable disease 64%, and in active brain mets 47%, which simply means that TDXD showed a consistent 1-year PFS in patients with either stable or active brain mets, as a very important improvement in the field. If we look at CNS PFS, the same results. TDXD showed a consistent 1-year CNS PFS of around 58, 57, and 60% respectively. Again, CNS overall response rate is in the range of 70 up to 80% in untreated population. When we have no baseline brain mets, the overall response rate is consistent with the previous data we have. Again, the overall survival in either patients having or not having a baseline brain mets was around 90.3 and 90.5% with the use of TDXD. If we look at the overall safety, no new safety signal, and the majority of adverse events were nausea, fatigue, constipation, but do not forget about the most important investigator-related interstitial pneumonitis and left ventricular ejection fraction decrease, very important adverse events. And the conclusions from Destiny Breast 2 is that TDXD, after these results, could be used in patients with HER2-positive, active or inactive brain mets. Very important shift for the treatment. So before Destiny Breast, this is the standard of treatment. We have first-line THP, and the patients with stable brain mets, TDXD was the first line, but patients with active brain mets, tucatinib was the preferred one. And if we look at the data just presented, the most two important now is HER2CLIMB for tucatinib and the Destiny Breast 12 for TDXD. And if we look focusly on the 2 trials, look at the CNS overall response rate. With the use of HER2CLIMB, it was around 47%, and here with Destiny, we have around 82% and 50% respectively. And definitely, I am not comparing a clinical trial, but no one can neglect the marked difference between the clinical trial, and this is why trastuzumab deruxtecan is supposed to be moved from further line of treatment to first line of treatment. And so TDXD is supposed to be the preferred agent, whether stable or active brain mets in the subsequent ESMO guidelines. And let's move rapidly to HER2 negative disease. And what we know about HER2 negative disease is that we have a similar incidence to HER2 positive, but shorter brain mets-free survival, higher rate of leptomeningeal disease, and we have different progression patterns because in HER2 positive, we can control the disease extra and intracranially. In HER2 negative disease, especially triple negative, we can not control the extracranial disease very well. And the level of evidence, by the way, for HER2 negative disease is not that high as compared to HER2 positive. But look at data we have. We have chemotherapy historical regimens around the response rate of around 50%. And if we look at patients with BRCA mutant in BRCA trial, we have talazoparib improving patients over treatment of physician choice for stable brain mets at baseline. Again, in Olympia A, we have a reduction of intra and the extracranial disease recurrence. Again, what we have in HER2 low disease, if we look at the DEBRA trial I just presented, look at cohort 2 and cohort 4, which included patients with active brain mets. And if we look at the right side, we have overall response rate of around 50% in cohort 2 and 33% in cohort 4, which is more or less reasonable. Again, all of us know the ASCENT trial, which led to approval of sacituzumab govitecan in triple-negative breast cancer disease. And if we look at patients with brain mets, out of these patients, look at the overall response rate, 1 versus 0. And if we look at median PFS intracranially, we have 2.8 versus 1.7, very low numbers. However, I cannot tell that sacituzumab govitecan is not working in patients with brain mets. We are waiting for a phase 2 trial dedicated for patients with brain mets because it is a subgroup analysis with a small number of patients. What we have else, we have Tuxedo-2 for triple negative with another ADC, which is datopotamab deruxtecan, and it included patients with leptomeningeal disease, and this is very important. We have earlier results, very good intracranial overall response rate. Again, we have Tuxedo-3, which is incorporating breast, lung, and leptomeningeal disease. Again, in HER2 disease, we have the Tuxedo-4. In the last ESMO, there was a very important agent, which is a promising one, ESG-401, which is a novel ADC targeting TROP2. And this is a patient's characteristics with a very good intracranial overall response rate of around 41 and the disease control rate of 73%. And these are the adverse events. And the conclusion was it is working. So in conclusion, we have HER2 positive disease and HER2 negative disease. The evidence for HER2 positive disease is much more as compared to HER2 negative disease. And we are now having a practice-changing clinical trial, which is DESTINY-Breast2, which is supposed to move TDXD from second-line treatment in patients with active brain mets to be used in the first line, whether having active or stable brain mets. This is the most important advancement we have. And in triple-negative disease, we have conflicting results. We are still away from having strong evidence for patients with triple-negative and even with HR-positive HER2-negative disease with brain mets. However, what we really need is clinical trials dedicated for patients with brain mets, because we can answer all these conflicting questions. Again, we shouldn't, or we should try not to exclude patients with brain mets from clinical trials in different brain mets malignancies. And with this, I thank you for your attention.
Thank you, Professor Dr. Ahmed Bastawisi, for your excellent and elegant presentation. Now I have the pleasure to introduce my dear colleague, Professor Dr. Ahmed Magdi, Professor of Medical Oncology, National Cancer Institute, and Medical Oncology Consultant at Bahia. Your presentation is about, is there more in the management of advanced breast cancer?
Thank you, Dr. Moro, for the beautiful presentation. So today I'm going to take you to what do we have in the future for breast cancer. So first of all, we have to highlight the importance of the NGS and how it allowed us to understand the cancer way more than before. Because now we can diagnose and dissect the DNA and looking at specific mutations. Because before we used a single gene, we were very happy that we found one target, and then the hotspot panel, and then with the NGS, we can find everything upfront and then plan accordingly. And it stopped, okay. So clinical trials, we do have 4,021 ongoing clinical trials based only on biomarkers. And this is an old slide from 2021. I'm saying old because now the advances is super fast. And what we have right now is 102 available targeted therapies. And this is beyond chemo. And if we look at the the growing evidence that the approaches that pharma companies and scientists have been going to targeted small molecules, you'll find that the cytotoxics are decreasing and the concentration is more on the targeted therapies and small molecular targets. And now we've heard about the pan-tumor indications, which we did not know before. And now we do have like the NTRK, the BRAF, and the MSI with the TMB, and PD-L1 more than 50%. What we learned also from the liquid biopsy is now we understand that we do have the CTC, circulating tumor cells, then the cell-free DNA, extracellular vesicles, and now the tumor-educated platelets. So the tumor itself is using the platelets to metastasize. Again, it's not, okay. Also with the liquid biopsy, we can use it in early cancer detection, the follow-up, the clearance, and actually the arising resistant mutations. Because with the liquid biopsy, if we're taking only the biopsy from the tumor, you can find only one mutation. However, when you take and we have all heard before in many clinical trials that we do have heterogeneous disease. So the metastasis is different than the primary tumor. So with the liquid biopsy, we can find that. And this slides just show you what we did with the NGS with all these available treatments, and I believe there are more for now. For the early breast cancer, I'm just going to quickly, because thank you, Professor Ola mentioned them, made my job easier, but I'm going to take the last part, looking at the ESR1, and this had led to the oral SERDs that are upcoming. Yes, they are in the metastatic, but in the early, these are already ongoing trials, no data whatsoever on them regarding the imlunestrant, and the camizestrant and giredestrant. These are used actually adjuvant after the CDK4/6 or in combination with CDK4/6. Time will tell us. The Geparnuevo, which was, I'm not going to go through quickly, but this is only using durvalumab as neoadjuvant, and just stopping with those achieving pathological CR, you will find that the overall survival was significant, but keeping in mind this is a phase 2 clinical trial, we're waiting for phase 3. The I-SPY 2.2, looking at the datopotamab, which is an anti-TROP2, in combination with the anti-PD-L1 durvalumab, and it showed that, yes, datopotamab, in addition to durva, may be effective among patients with immune-positive subtypes according to the TILS infiltration. What about the TROPION-Breast3? Again, was mentioned before with the datopotamab, with the durva. Again, we're waiting for the trial, the results. The ABRAVE, as Professor Ola told us, was with the avelumab maintenance. We all know we've seen the avelumab maintenance in the bladder cancer, and now it is embedded in the guidelines. What about breast cancer? We're still waiting for that. But this is to show you